Good morning, everybody. Good evening, everybody, whoever is watching us from all over the world. Thank you for giving me this opportunity to introduce the World Autism Organization. My name is Petra Dilman. I was born and live in Namibia in Southern Africa, and I have a 32-year-old son with autism, which set me on the autism path. I've been a member of the World Autism Organization since 2000 and on the executive since 2014. The World Autism Organization was established and sprouted out of Autism Europe when they found that there was much more to be done than what they could handle as Autism Europe. So Autism Europe is mainly concerned with matters in Europe and around Europe. And the World Autism Organization since 1998 has been trying, and in some ways successful, and in other ways, because of challenges, it's still difficult to reach everybody. It's very difficult to bring everybody under one hat with languages, with distances, with understanding, with different cultures, but we are doing our best. And the World Autism Organization wants to provide a global response to the needs of people with autism and their families, and to promote the implementation of the United Nations Standard Rules on Equalization of Opportunities for Disabled People. This was signed in 1983, but nowadays we have moved to the UNCRPDs, which is the UN Convention on the Rights of People with Disabilities, so autism falls under this umbrella as well, implementing the Convention on the Rights of People with Disabilities, as well as aligning them with the Sustainable Development Goals where it is needed. People with autism have an indisputable right to live independently, self-advocacy and involvement as far as possible in decisions affecting their future. And I'm glad to say that we're finding more and more people with autism also joining the World Autism Organization, because from them we can actually learn the most. By listening to people with autism, we have a way to the future of what to do and how to go about it. Accessible and appropriate education, housing, assistance, care and support services, and sufficient income are also all rights of people with autism, as with anybody else in the world. And they should have freedom from fear, threat, and from abusive treatment, which unfortunately is still happening, but thanks to internet and what these things get sort of like not hidden so much anymore. We, as the persons with autism advocating for ourselves and parents advocating for our children with autism, with the contribution of professionals who share our views, pledge ourselves to press for these rights to be enhanced and enforced by appropriate legislation worldwide. The council members and executive members of the World Autism Organization are involved voluntarily and are located in several countries over the world. We are pleased and grateful to have signed the MOU to collaborate with the Autism Research Institute, as the themes and difficulties are the same all over the world, and it's nice to network and to work towards a common goal. The children of the people who started the World Autism Organization are all adult now, many of them over 50 already. Our services and information sharing need to expand to give the appropriate help. To this end, we need everybody's input and dollars. Each dollar makes a difference, especially in poor countries with weak exchange rate. A dollar goes a long way. Go to the WAO website to find out more and to become a member. www.worldautismorganization.com. It is only $15 per year, and many people cannot even afford that. Thus, we have implemented a system whereby you can gift membership, and we are most grateful to be able to give it to people who apply for this gift membership. And then we, unless you have a specific person in mind, you can say, well, WAO gift committee can then give it to whoever has applied. If you'd like further information, you can also email to info@worldautismorganization.com. And now over to Dr. Bauman. We're looking forward to your presentation. Thank you for your time, and thank you to Ari once again for organizing this event. The first time I heard of Dr. Bauman was in the 90s, actually. So I was very, very pleased that she's on board and that we are able to speak to her tonight and listen to her tonight. Thank you.
Okay, thank you, Petra. My name is Dr. Steve Edelson. I'm the director of the Autism Research Institute in San Diego, California. Now, let me first say a few words about the Autism Research Institute, or ARI, or RE. I've heard many ways. ARI was founded by pioneering researcher and parent advocate Dr. Bernard Remland in 1967. This is our 55th year of monitoring, supporting, and conducting research. More specifically, ARI funds research studies, sponsors an international support group network with over 250 member groups, as well as a science network, sponsors think tank meetings, and publishes original articles and books. We also produce videos and webinars and a lot more. And you can learn more about ARI at www.autism.org. As for today's speaker, Dr. Margaret Bauman, I've known her for many years. She is one of the leading medical researchers throughout the world and has contributed in many ways to our efforts at the Autism Research Institute. Dr. Bauman is a pediatric neurologist and associate professor of pathology at Boston's University School of Medicine. She is also founder and chair of the Autism Research Consortium. In addition, she is a member of ARI's Scientific Advisory Board. Today, Dr. Bauman will discuss the importance of providing optimal, not minimal, medical care for adults and seniors on the autism spectrum. For far too long, appropriate and timely care for these individuals has been ignored by the medical community. We all need to work together to improve the quality of care and support for all individuals on the autism spectrum. So, Dr. Bauman, welcome.
Thank you, Steve. It's great to be here, and I want to thank the WAO and as well as ARI for asking me to participate in this meeting. It's a very exciting opportunity, and I'm thrilled to be here. And appreciate the introduction. Just to start off by saying that it's probably a little strange that someone who is a child neurologist is giving a presentation on adults and aging in autism. And I just want to make a comment as to how this has come about. For many years, as most people, and probably even still at this point, autism is still perceived largely as a childhood disorder. We're now recognizing more, obviously, teenagers and young adults. But the area of looking at seniors and aging in this field is still very much an unexplored area of research, as well as clinical investigation. And so I think that we're kind of on the cutting edge here of trying to come up with some strategies, some issues that relate to the treatment and management, identification of medical issues as it relates to the aging process in autism, which remains to a large extent unknown at this time. So this is how, to some extent, I became involved. The other way that I became involved is because, as you'll hear as part of this talk, the medical resources for adults on the spectrum are really very minimal, at least in the United States at the moment. And so those of us who have been involved in child neurology or pediatrics, or developmental pediatrics, have been obliged to carry on with many of our patients that we've had as children who are now adults. And so even though that may not have been our original area of interest or area of expertise, is something that we have essentially grown into out of necessity to care for these patients long term. So this is a little bit why a child neurologist is giving a presentation on the aging in autism. And I hope that the comments today will at least raise some questions about what the issues are and how best we can move forward. in terms of solving some of these challenges. Clearly, since I am located in the United States in the Boston area, some of the comments may be related to what is going more in the United States than in other countries elsewhere. Each wish, I suspect, have their own challenges. But I hope that at least the principles that we're talking about will be something that everybody can be aware of and at least begin to raise questions about how we can move forward here. So just to get started, what are some of the medical problems for aging in the autistic adults as we see them at this point? And one of the big challenges, as I've just mentioned, is to find a primary care physician, a PCP, who is interested in accepting adults on the spectrum in their practice, or B, has any kind of expertise to do so. And as I said earlier, it seems to be a very small quantity of individuals, its practitioners, providers, who are willing to take on these patients for a number of reasons that we'll talk about a little bit later, but also who have the skills to do the job. And so consequently, as I mentioned, much of this is still being carried on by those of us who came out of the world of pediatrics. But this is a huge challenge right now. And I think a lot has to do with the lack of training that most of these people have had during their medical school experiences or through their graduate programs. Then there's the issue of if one of our adult clients comes to an emergency room or to a hospital, are the staff in the hospital prepared to deal with the complexity of a patient who presents with an autism profile? And this also seems to be quite limited right now. There are some hospitals, at least in the Boston areas, that have put together teams of providers in the hospital, or at least some person, it could be a psychologist, it could be a social worker, someone who has got experience with the autism world, who at least can guide staff once the person is in the emergency room or the person has been admitted to the hospital. The challenges in an emergency room are enormous, not just because the medical complexity of the patient presenting, but because of the confusion sometimes in the emergency room. It usually is a busy, noisy, hustle, bustle sort of place. And the routine that our patients are typically used to or do better in just really isn't part of the profile there. So I think some adjustments need to be made in terms of how individuals on the spectrum are managed within hospital settings and emergency rooms, which is again just now beginning to become up on people's thought processes at this time. And then, at least in our country, the insurance companies are challenged by the multiplicity of care that a lot of these folks require. And not only that, but many of them do not carry private healthcare insurance. They often will have state-supported or federally supported healthcare insurance. And this then limits their opportunities and the availability of services in many cases to large institutions or academic institutions. And some of these places are overwhelmed with long waiting lists, which doesn't provide immediate services to somebody who perhaps needs something performed urgently. So there are significant concerns here in terms of how simply just to identify and access just basic services from a healthcare perspective. Now, many of the medical concerns we're going to talk about a little bit later, but are reflected in this sort of this short list at the moment. But medication management. Well, we've got some clients who can't swallow pills, and so we need to put it into some kind of a liquid form, or that has to be able to have a certain taste to it, or something of this sort. Or how often is the person being provided with the medication? Can this person self-medicate, or is this somebody who requires oversight? Gastrointestinal issues listed here as GI. are a growing concern at this point. It's now become very obvious that gastrointestinal issues are a fairly significant associated comorbidity in the autism population, regardless of age. We certainly have identified it in children and adolescents, and there's no reason to believe that it's going to be any different with the adults or the aging population. And we'll talk about that a little bit more. Sleep disorders, certainly typical adults can have sleep disorders, but these can also be present in the autism population. Some of this can be related to sleep apnea, which necessitates perhaps using what's called the CPAP machine. That means putting a mask on your face. If you've got sensory processing problems, that's not going to be handled very well. So how does one deal with someone who has those kind of problems? Dental care. I don't know how regularly a lot of these people can access a dentist. Most adults, neurotypical adults, do this on a routine basis, but if one is an adult living in a group home or some kind of community residence somewhere, who is ensuring that this person is going to get routine dental care? And if in fact they have some kind of issue that needs to be addressed, how is that going to be handled and where? Obesity is a prominent problem in many of these folks, maybe in part because they tend to be less active, and they may go out for a walk, but they're not likely to be somebody who's going to go regularly to the gym to work out or to run every day to do some kind of routine exercise. And also they tend to have high carbohydrate diets, which sort of leads to being overweight. So that's another issue. Seizures, I'm sure many people here are aware, can be a lifelong problem in this disorder. Vision difficulties, I don't think that we often think about vision difficulties in this disorder, although among the younger population, we found out that many of them will have difficulty with what's called visual tracking across a horizontal plane, or maybe have problems with depth perception, but they could also be nearsighted or farsighted. And how do you even evaluate such a person to find out whether they truly need glasses or there's something else that needs to be done? And then the issue of preventive care, which we've sort of already begun to talk about. Who is going to be the person that's going to monitor these individuals as they get older, and to be sure that they're getting care, advanced care, to rule out potentially serious conditions as they age. So these are some of the just basic challenges of this population that, frankly, I think the medical world at this point really is underprepared or not as well prepared to deal with as it should be. So what kinds of limitations are here? So we've got, as we've already talked about, limitations in terms of the number of primary care physicians who are willing or able to take on an autistic person. And part of this is because they just they're not familiar with what autism is. Most of these people are adult doctors, and this simply hasn't been part of their education, either as residents or interns or medical students. There's also limited time that a doctor has with each patient. Many of our primary care physicians, for example, we may see 4 patients an hour. They are limited to 15 minutes per patient, for example. Well, the chances of being able to see a complicated, potentially acting out adult in your office for 15 minutes and come out with some kind of meaningful evaluation is probably pretty low. And so that would mean that the doctor would have to allow more time. Then does he or she get paid for that extra time that they're putting in? So there's a very complex issue here that has to be dealt with in terms of just the amount of time that any physician is able to provide for the specific patient. And then there's the paperwork. Regardless of where a lot of these folks live, whether it's in their home or whether it's in a group home or in a community residence somewhere, there's almost always some kind of paperwork that has to be filled out either because of the insurance issues or because there has to be some documentation to the people who are sort of providing oversight for this person, be it family or a professional provider somewhere. And just because of the logistics, the government wants documentation about what happened, what kind of medications they're on, how long are they going to be on the medication, who's going to monitor it, and so forth. And all of this needs to be documented. While it's helpful to have this available online through various electronic means, there still is a lot of, quote, paperwork, real paper that has to be filled out as well, and so that this can go into a medical record somewhere and be documented. We in the United States, we have what's called Medicaid and Medicare reimbursement, which is basically state-supported or federally supported healthcare insurance. And generally the rates that these agencies will provide, or reimbursement that they will provide for any physician or provider, is very low. So there's very little incentive for a primary care physician to want to take on these patients because they just aren't going to be making the money that they need to make to keep their offices open and pay their staff. So many of the folks who require this kind of services end up you typically using the larger academically related hospitals that accept these kinds of insurances. The downside of that is that oftentimes these hospitals have very long waiting lists. And sometimes it would not be unusual for a patient who has a healthcare issue that needs to be addressed to have to wait 3 to 6 months in some cases because of the volume of individuals who need that care and who are on these waiting lists. So it's a very complex problem, and it really is a problem in terms of how can we possibly address the needs of the adult and most especially the aging population. So the other issue is the diagnostic challenges. And I suspect that many of you are aware that many of our clients, our patients who are on the autism spectrum, do not present with the symptoms that are easily recognizable to the average primary care physician. And again, I think it's because they haven't been trained to think about it. And even as a specialist, for example, let's say that we have a gastroenterologist, and that he or she is presented with a patient with some unusual symptoms. Well, most of these people do not typically think beyond their own discipline to think about anything that could be causing something that could mimic a symptom that they have. So how can we begin to teach people to think out of the box and beyond their own discipline, to consider, the patient's presenting with some kind of unusual behavior? Is this, in this case, a gastroenterology problem, or is this some other kind of a problem? How is this being presented? And I think that I'll describe in a minute some symptoms that are sort of red flags, if you will, for individuals who have gastrointestinal disorders. And this is just an example. It's this could be an ophthalmologist, this could be a sleep specialist, it could be other specialties. But it has to be someone who is familiar with the fact that these individuals do not present with typical symptoms. They don't, and many of them are nonverbal, so they can't verbally say, I hurt, it's here, or it's something, I don't feel well because, or even if they are verbal, some of the verbal bright patients that I personally have seen can't always identify these problems either. And I think some of this relates to the fact that there are some sensory processing issues here, so that even if they don't feel well, I've had several of them tell me something like, well, I'm not feeling well. It takes me about 3 or 4 days to understand what the problem is. It's not easily solvable for even the patient themselves. Many of these patients will present with atypical or disruptive behaviors, which at this point we're now concluded may represent pain and discomfort, even though the patient isn't saying I'm uncomfortable. And I will just relate a few little anecdotes. I hope that will bring out this comment, this point. I have a young woman, a young adult, who came to the office with her parents, and she was complaining of, well, she's basically a hypoverbal adult. And she was hitting her head, and the one thing that she could say was head hurts as she was hitting her head. And this had been going on for quite a while. And the parents came in and they said, we really think that she has headaches. And I said, well, because I knew about some of these atypical symptoms, because I've been working with other specialties, said, I think your daughter needs to see a gastroenterologist. Now, this is a woman who is not presenting with any vomiting, diarrhea, constipation, any of the symptoms that people would obviously think about going to a gastroenterologist. And I remember literally saying, I know you're going to think this is a crazy idea, but I think this is really where we need to start. Anyway, she went to the gastroenterologist who performed an endoscopy, and she came back with a diagnosis of esophagitis and gastroesophageal reflux disease. She was treated, and as a result of the treatment, no more comments about head hurts and no more hitting her head. So it's not obvious that this was a case where you ought to go see a gastroenterologist, but one has to start thinking about some of the behaviors that these individuals are exhibiting that are so atypical that we have to think beyond the obvious here. This is likewise for sleep problems that we will talk about in a bit, and also excessive tantruming, self-injury, which is like the head hitting things, or even striking out at others, which we'll also talk about in a bit. But the point is that these symptoms are not typical, and oftentimes they can present as behavioral manifestations, because I think this is these folks have a very limited way of telling us that they're uncomfortable, or they hurt, or that they don't feel well. And so we have to be a little more like an investigator, thinking out of our own specialty to figure out what's going on here. So this is an example of some of the behaviors. If in fact somebody is presenting potentially with who needs a referral to a gastroenterologist. And oftentimes when I give a similar talk, I will show a video of some of these individuals with the behaviors that I'm describing here, because I think a picture is worth 1,000 words, but we weren't able to put up the videos today, so I apologize for that. But I did want to talk about this a little bit. So if you have someone who comes in and who's making a lot of gulping noises, or head stretching, like they're stretching their neck a good deal, that can be consistent with a gastroesophageal reflux disease. I've had patients come into the clinic and they walk immediately over to the sink, the faucets in the sink in the examining room, and press their stomach against the sink, causing pressure on the stomach. So putting pressure on your abdomen to relieve some of the distress there, and to then give us the clue that maybe there's something going on here with the gastrointestinal tract or the abdomen. Tapping on the chest, I've seen that repetitively. Disruptive sleep patterns, how should this fit? Well, possibly if one has reflux, gastric acids you lie down in bed and gastric acids then come up through your esophagus and gather in the back of your throat, and will keep you awake at night, or will wake you up in the middle of the night. So if we have disruptive sleep patterns, one of the ways that we can kind of think about why those patterns are disruptive is to say, is this potentially a gastrointestinal issue as opposed to just a behavioral issue or a basic sleep disorder? It at least is an area that deserves investigation. We talked a little bit about self-injurious behavior. This could be head hitting. This could be, it could be biting. I've seen biting. I've seen scratching and creating lots of scabs and skin lesions on the body. And again, I'm not sure why they're doing that, except this is certainly is a manifestation that we've seen in gastrointestinal disorders. We've talked about aggression and unexplained tantrums, particularly if these are relatively new. If someone is starting to do these for unexplained reasons, I think a referral to a gastroenterologist will be important. Chewing on non-edible items. A lot of people chew, a lot of these folks will chew on their shirts or their sleeves of their shirts. or their collars or their neckties or whatever it is that they're wearing, or some other item that they have. And sometimes we think of that as being a sensory issue, but I think in other cases it probably isn't. And also that would go along with the frequent snacking or drinking. And the hypothesis here is that when one is chewing on non-edible items or snacking or drinking, that you're creating saliva. And the saliva then is swallowed and is soothing to an irritated esophagus. So it is important to think about, again, beyond, is this just somebody who's got an odd behavior and that's why they're chewing on these non-edible items? Or is this trying to tell us that there's something about the GI tract that we need to further investigate? So this is just one example of a group of disorders that do not typically present as, you know, the obvious gastrointestinal symptoms, but are presenting as various atypical behaviors that people have to be aware of. And therefore, if we're going to make referrals to specialists, these specialists have to be trained to recognize these unusual behaviors, because you can't simply say, oh, well, he doesn't have vomiting, diarrhea, constipation, or whatever. So this is not a GI tract issue, when in fact, some of these other signals, which are atypical, are giving us the clues. In terms of the diagnostic challenges, we really do need valid and reliable diagnostic tools to address the adults and the seniors, which we do not have. We've already talked about the fact that many of them are nonverbal and they can't indicate their symptoms. They aren't really able to accurately point to or tell us about their discomfort. And because we think to a large extent, this is a poor safety awareness. A lot of them have these very restricted diets, and some of this may be sensory loaded in terms of tolerating certain either tastes or odors or textures. A lot of them, as we've already talked about, have a high carbohydrate diets. And all of this needs to be addressed by somebody who's knowledgeable in the field. So medical conditions, there's nothing special, I don't think, about the kinds of medical conditions that your a typical adult, senior, autism person is going to be exposed to and present with. I mean, these are a list that would be consistent with any person who is an adult, probably even a child or an adolescent for that matter, might be bothered by. But the question here is how many people are really screened for many of these disorders. I mean, seizures are fairly obvious. I mean, if somebody has a seizure, oftentimes they're seizures that began when they were children. They're on medications. Occasionally they'll have a breakthrough. People observe. So that's considered to be, a fairly common disorder associated with autism at any age. Cancer, not so much. I think of all the populations that I have, I think I have only 3 patients who have had some form of cancer. So I will talk about a little bit about the screening and preventive care in a minute. Metabolic disorders, I think there's a growing interest in metabolic disorders, particularly in the autism population. And there's now some growing body of research that talks about associated mitochondrial disorders, particularly in autistic people who have gone through early regression. Seems to be some correlate there. The question is to identify them and potentially provide some care. I don't think we can cure this problem as yet, but I think there are means of modifying it. Cardiovascular disorders, certainly they can have this as well as anybody else can. Hypertension, cardiovascular disease of any cause or type should be investigated. Diabetes, particularly given the tendency to be obese, is fairly common in the high carbohydrate diets, and generally lack of exercise. Arthritis, I don't know if anybody really thinks about some of these folks as having arthritis, which could be fairly painful. Gastrointestinal disorders, we've talked about a little bit. And there'll be a whole host of those, including colitis, Crohn's disease, celiac disease, gastroesophageal reflux disease, a myriad of gastrointestinal disorders that need to be addressed. and then tardive dyskinesias, which may be related in many cases to some of the medications that some of our patients are getting. All of these and many, many more that are not even on this list really need to be considered. There's nothing different, I think, physically from the person who's an adult on the spectrum that shouldn't be considered as you would for any other typically developing adult or senior. Medical-related conditions out of any of these are this chronic pain story, which many of our patients cannot tell us about. We do not know. I mean, if they have back pain and they're nonverbal, how are we going to know that they have back pain? I mean, they don't typically point to it. They can't tell us. So how do we figure that out? We talked a little bit about dental issues. If you have pain in your jaw, you've got a cavity in your tooth, you've got an infection in your gum, is that going to be a problem? Sleep disorders, we talked a little bit about that. Balance and motor challenges. Many of these folks have had low muscle tone and relatively poor, I guess, coordination as children. I wouldn't say it was poor, but they certainly, to find an autistic person who's particularly athletic is unusual. And so I think as they get older, balance and motor coordination issues accelerate. And certainly they do for the normal aging population as well, but also probably more so for this group. Sensory processing issues, we've talked a little bit about. We've talked about vision. Vision can be nearsighted, farsighted, astigmatism, visual tracking, depth perception, a whole host of things. And for the most part, I doubt seriously that many of our patients are getting routine vision screening. And for somebody who's nonverbal, that's also a challenge for somebody to proceed with that. Hearing evaluations also are not typical of something that most adults on the spectrum get, although we know that hearing can decline with age, growing age in some cases for hearing aids. I can't think of any of my adult patients who are now wearing hearing aids. And furthermore, even if they needed a hearing aid, the question then is, would they tolerate it from a sensory perspective and having something put into their ear canal there so they could hear better? So this is, I think this is an unknown question that nobody is addressing as far as I can tell. Vestibular function, I think is very difficult, and most of our clients are not getting occupational therapy as adults. What's their balance and equilibrium like? And then tactile and taste and smell, odors, all can be significant factors here that are contributing to any kind of medical condition or are part of some kind of medical condition. Either way, they're all areas that need to be considered here. It's really complex and challenging. And then there's the mental health conditions. I mean, we get, probably even in the typical population, we probably don't give as much stress to mental health conditions as we should. But I think a lot of our patients can be under a great deal of stress, and particularly, frankly, given the pandemic at this time with social isolation, which is the bottom list, it can be extremely challenging. And I think that we're seeing a very high level of anxiety and depression, not I think in the general population for one thing, but certainly among the autistic population. It's just huge in the distress that a lot of these people are undergoing because their schedules have been changed, their routine has been changed, their staffing has been changed, there's understaffing in some places, people who've been having home care facilities, and the staff might get sick or they're COVID positive, and so there's some other person comes in or they don't come at all. So it's extremely stressful right now for all kinds of reasons. The issue here of dementia I'm bringing up because there are a number of surveys that have been done that raise the question of dementia. And I think this is a curious piece, at least from my perspective. Many of these, for example, the Kaiser organization on the West Coast have published some data out of their database. And they've gone through for example, the last 10 years in their data and to look at what are some of the diagnoses that an adult on the autism spectrum may present with? And a certain proportion of them are labeled as dementia. And I'm confused by that personally, because I don't know how one defines dementia in somebody who has got potentially a developmental delay and may be nonverbal. I mean, is this simply somebody who has had little exposure to community-based opportunities, or doesn't read books, or doesn't listen to music, or is really sort of isolated, and therefore they just understimulated? Or is this somebody who's got some documented regression that's going on that may be dementia, but it could have some other causes? How do you define dementia? Who's making these diagnoses? What kind of dementia, if it is dementia, are we talking about? So I think that, again, it's easy to throw a lot of these terms into a basket and just put it into some kind of computer base without really understanding what the issues are, or whether this is really truly the correct diagnosis. And I don't think we have any idea what that looks like whatsoever. There is some data that talks about a small group of people who have been diagnosed with Parkinson's disease among the autism population. I don't know that I've ever seen any reports that report on multiple sclerosis in this disorder with aging or at any age. Nor have I seen anybody publish anything about Alzheimer's disease. Whether that's the dementia piece or that's something else, I think remains as yet to be determined. So it's, again, our primary care people are undereducated about this population. Certainly our psychiatrists are equally undereducated in terms of the mental health conditions that most of our seniors and adults would experience. So preventive care, this became, probably came to the forefront in my thinking. It's not something that I personally have been thinking about very much until one of my patients in his late 60s was diagnosed with prostate cancer. And I then became aware that most of our adults on the spectrum, or with developmental disabilities in general, rarely get screened for the usual things that most typical people would be screened for. So how many people do we know, women, get regular breast mammograms for breast cancer, or tested for cervical cancer, whether they're living at home or they're living in some kind of group or community environment? Likewise, for diabetes, hypertension, some of these other disorders, I don't know how often they get screened. Women who have dysmenorrhea, trouble around their menstrual periods, this can be much associated with behavioral disruptions because they're not comfortable, or they've got pain or distress by that. But I don't know anybody who's really taking on this population. I get very few of my own patients, and I think those that I've heard about from others, ever get screened for any of these most of the rest of us would see as fairly common procedures. And there are other kinds of, how many, we've already talked about this, how many people are actually getting vision screening on a regular basis, or audiologic evaluations for their hearing. I think very few, very few. Oops, sorry. Nice. So parting words are that many of these medical problems that these folks have had as children certainly can continue their lifespan, along with new ones that happen with aging. The communication deficits and the sensory differences make this really challenging. It makes it challenging for people to, for providers to evaluate them. It makes it challenging for them the patient to express or indicate what's wrong at the time. And so this whole field is just at the moment underexplored, and we're on the brink of trying to begin to put things together here to come up with some methods by which we can start to evaluate these folks in a meaningful way. There's a lot of work that needs to be done in terms of not only the quality, but the quantity of medical care that's provided for aging individuals on the spectrum. And I think much of this really goes back to the lack of training that we're providing for our doctors during their medical school careers or their postgraduate programs. I think even on some of our major hospitals, if somebody who is going through a pediatric residence has an opportunity to rotate through through an autism clinic program, it's usually 1 day or 1 hour or something of that sort. And given the prevalence rates of this disorder, it's inconceivable that regardless of what specialty somebody may eventually go into, that they aren't going to come across one or more of their patients who are on the autism spectrum. One of the hospitals in which I work out in California has had 1 or 2 autistic persons who have ended up in this rehabilitation hospital for a variety of reasons. And what has happened is that I don't want to say there's this panic, but I will often get a frequent phone call. We need a consult right away because of this patient with autism has been admitted and nobody knows what to do. So they most of the time they don't even think that they're going to need that help. And then when some adult patient shows up, they get panicked because they don't know what to do. How do you communicate with this patient? How do we figure out what's going on? How do we get the patient to do the exercises or the therapies that we want them to do? So it's unknown territory. And I think any and all of us, as Steve Edelson has already mentioned, this is going to take a village. It's going to take several villages to begin to start to sort this out and to come up with some strategies to approach folks on the autism spectrum as they get older into adulthood and certainly into their senior years. So parting words, our family and professional advocacy and policy changes are badly needed. And it probably doesn't matter where in the world you live. This is uncharted territory, and we absolutely need to get going with this. The idea that this disorder is just for children and adolescents is long gone, and clearly the children and adolescents grow up and they become adults, and this disorder does not disappear after high school or college or university or whatever. There are going to be people out there who are living with this diagnosis and who are going to have needs going forward into adulthood. And there's nothing about autism that is going to shorten your life expectancy, at least as far as I can make out. There used to be some thought that people on the autism spectrum had early deaths that may have been related to accidents that they had or something else that was happening. But at this point in time, there's no evidence that there are individuals on the spectrum who are going to have short life expectancies. Excuse me. So the fact that we're going to have many of these children growing up into be adults and seniors is on the horizon, and I think we need to be prepared for it. And there now is a growing awareness of the needs of these people, and I think we need to get down to business and start doing something about it. So I'd be glad to entertain any kind of questions. I'd welcome any comments and any suggestions that anybody has that would help us to move this project forward. So thank you very much. It's been a pleasure to be part of this group, and I hope this raises some questions so we can get started with some policy changes. Thank you so much.
Well, Margaret, thank you. There are quite a few questions, and for people who are still typing their questions, please enter them in the Q&A section and she'll answer as many as she can. The first one, this person is asking about resources that are available to assist seniors. So I know you talked about that a little bit. Can you talk just a bit about, as seniors age and parents are no longer able to provide medical management, what have you seen either be effective, or what have you seen in terms of the outcomes? So parents are no longer able to do it. What happens with those seniors?
Oh, that's a very good question, and it's probably, as usual, a complex one. Sometimes there are siblings who will take over as the resource. So somebody who has a brother or a sister or some family member who will be the supervisor, and that the parents have made those arrangements before they passed away, that this person now has a guardian or some conservator who will oversee their care. I think otherwise it comes back to the state or the government to appoint someone. I do think that folks on the autism spectrum, particularly those who really cannot make medical decisions or financial decisions on their own level, on their own given their own cognitive abilities, really do need to be assigned an overseer of some kind, whether that turns out to be someone from an agency who's a social worker or a psychologist or some other personal care physician of some kind. But there needs to be somebody who is assigned to each one of these individuals who will play that role. And it should be, I don't know exactly how this would be funded. That's really a question, but somebody needs to be assigned. At least in this country, when someone turns 18, if they don't have the cognitive abilities or the insight, I guess, to make meaningful decisions on their own behalf, then in fact someone is assigned as to be their guardian, and who is then the one that becomes their overseer. And I think somehow there needs to be some kind of policy where someone is assigned to a person such as that, who will then be that person's overseer. Now that's fine to a point. I have one man who comes from a family that's got means, who has who is in house and whose family has provided staff, but then they get concerned because the staff is aging, and now we're going to have to find new staff to come in there to take over. So if the person who is in charge of the conservatorship or the guardianship is aging, or in fact gets sick and dies, then who's going to take over that role? So I think that there does need to be some insight. I don't think that I've got the solving the problem, but there does need to be some kind of arrangement somehow for individuals on the spectrum, or anybody with a developmental disability for that matter, to have some kind of assigned oversight lifelong. Excuse me.
Okay, so the next question here is about sleep. So I know you've talked a bit about the prevalence of sleep problems in people with autism. So as people age, have you observed just clinically that worsens? I know that can worsen for anybody in the senior population, but have you seen that consistent in the autism population? And then with those problems, are those treated differently than obstructive sleep apnea? For example, are the conditions similar in symptoms and treatment as standard sleep disorders?
This is a good question. I don't think that I've seen it. I'm not a sleep specialist. Okay, so let's start with that. So my population for sleep disorders in adults on the spectrum may be fairly limited, but I don't think that I've seen any higher frequency in this population versus the typical population. It does occur. And from what I can make out, from what I hear from my patients, their parents, their caregivers, and have read their records, that they seem to be treated very much as one would treat a neurotypical person. They go in, they get a sleep study, they are put on certain medication if that's needed. If they have sleep apnea, they have a CPAP machine that they use, and I do have some adults on the spectrum who are in fact using CPAP machines. They don't love it, but they do use it, and they are followed usually by a sleep specialist somewhere. So I don't see it as being any worse or better than the typical population, and I don't see them being treated as any in any different way, at least as far as at least at this point, I don't see that. I don't think that a lot of them are necessarily being evaluated for other potential reasons that they have the sleep disorders. So for example, this was a teenager, but this was a young man who came in and was having sleep problems. And his mother said that he snored and he made noises. And I said, well, I think it's a good idea if he got to see an ear, nose, and throat specialist, because maybe he's got big tonsils and adenoids and he can't breathe well enough to really sleep really well. And so I sent them off to an ear, nose, and throat specialist. And they came back the next time and I said, well, so what did the doctor have to say? And they said, yep, he says, this young man has big tonsils and big adenoids. And I said, well, is he going to take them out? And the mother said, no. And I said, well, why not? I mean, if you can't breathe, you can't sleep. And she said, well, because he's autistic. And I thought, I don't care what the diagnosis is. The poor man can't sleep adequately because he's big tonsil and adenoids. You need to treat this as you would treat this anybody else. It doesn't matter that he's got autism. So this is, again, gets back to the skills, the interest, the professional adequacy, I think, of our healthcare system. The fact that somebody would make a statement like that, I found really offensive, quite honestly. So anyway, as far as I can tell, they're being treated very similar to typical people.
Okay, so there are quite a few comments here where people are sharing some resources. So I'll share these with you because I know you're always looking for information about that.
Sure.
One was just a thank you. This parent is thanking you for touching on so many issues that parents face, even just through the early transition to adult care. So people are appreciating that information. This person's mentioning a resource, Healthcare for Adults with Intellectual and Developmental Disabilities at the Vanderbilt Kennedy Center. In 2018, they have a toolkit for primary care providers.
Right.
So, and they hand out called Communicating Effectively for PCPs to Use. So you may be aware of that, but I wanted to share that.
Thank you.
Yeah. And then there's also this parent in England is sharing. In England, my daughter who has autism has a purple folder that is accepted throughout by doctors and hospitals and gives her priority. Do you have this in the US? I think not, but that might be something to learn about.
Mm-hmm. Sounds good.
Yeah, and then one more, I'm going to scroll up here. This person had a good experience in Atlanta. They asked us to mention the Adult Disability Medical Healthcare at admh.org. It's a clinic in suburban Atlanta where they were providing multidisciplinary care and had a model where they were addressing several of the different issues that you're talking about. So if there are parents in that area who are looking for a resource, that may be worth exploring. One person here is asking, do medical conditions associated with aging typically appear earlier in life in adults with autism than in neurotypical adults? So asking if these things turn up in their 40s or at an earlier time.
Not that I'm aware of. I mean, they seem to be fairly typical in terms of the age of onset. I don't see this as being any earlier or frankly any later either. But again, a lot depends upon who's doing the screening. If you don't do the screening and evaluate people, then you're not going to pick it up. So I don't know whether the data is skewed or not. But as far as my personal bias is, I don't see this as being any worse or better than anybody else. In fact, frankly, some of the adults that I see are pretty healthy, regardless of the fact that they may be a little bit overweight or they're having terrible diets or they don't exercise or whatever. Many of them really, frankly, look pretty good. So I don't know. It's a good question, but I don't see any age difference.
Okay. Do you have any tips or tricks for healthcare providers who work with folks with autism to better tolerate assessments and procedures? So I know we talked about this a bit yesterday, and are there strategies that you've used just in the clinic that you can generally say can be really helpful?
I think having somebody, if this is an office, a clinic that's going to take care of folks on the spectrum, then there needs to be at least one person in the clinic who's got the experience to be helpful. So I don't know whether this is a nursing assistant or this is a social worker or somebody who's got the background and who can provide extra help to the physician, the provider, whoever who is seeing the patient. I think that's enormously helpful. And I suspect that's what's happening in the number of clinics that you've already alluded to in the Atlanta program, which is a multidisciplinary program. That's what we have done elsewhere in our own clinics. To have a variety of people who can provide these resources. For somebody who's just got an ordinary office, I think that, if they've got at least one person in that office who has had at least some exposure and has some background in that would be enormously helpful. I think listening to some of the webinars that Dr. Edelson had talked about is also useful. If you're going to accept individuals on the spectrum, then at least, somebody in the group needs to be at least knowledgeable or trained, have their index of suspicion high enough. If you've got somebody with a behavioral problem who comes in and has a behavioral problem in your office, how are you going to handle that? Do you have an extra a place where there's sort of a quiet room where this person can go and not have to sit in the waiting room or be bothered by loud noises? You know, do you have some accommodations that would provide in the event that you really needed those services? But I think, you know, taking advantage of some of these webinars and service programs online, I think could be enormously helpful just as a starter.
All right, so a couple of questions just about comorbidities, and you addressed some of this in the talk. These are two I'm not sure you specifically mentioned. They're asking about a connection for seniors with autism, whether or not you've seen any connection with Parkinson's, so a Parkinsonian prevalence in that population, and then also about Ehlers-Danlos syndrome and whether or not that worsens with age. So this is one you may not be able to answer, but I wanted to share these questions.
Okay, I personally have not seen Parkinson's disease. As I mentioned, the paper, the only paper I've seen is the one that came out of North Carolina that was co-authored by Dr. Joseph Piven, P-I-V-E-N, where they reported a subgroup of individuals who demonstrated Parkinson's disease. There are a number of individuals, really, the most of them I've seen is really late teens and early 20s, who have presented with catatonia. Catatonia is not the same thing as Parkinson's disease, but they also can, pardon the expression, get stuck. There's this real problem with initiation of motor movement, but they don't have some of the cognitive, the rigidity and other features of the disorder. So I don't think this is Parkinson's disease, although I think it could be confused with Parkinson's disease. But I'm willing to buy into the fact that some people may get Parkinson's disease, but I don't think it's frankly, it doesn't seem to be highly prevalent as far as I can make out, except for this one paper. This is the only paper that I've ever seen. Now, what was the other question? I'm sorry, I missed it.
They were asking about Ehlers-Danlos.
Ehlers-Danlos. Okay, yeah, okay. Ehlers-Danlos with the low. I don't think it gets worse with age. I just I have a number of families that you know, have it in the family, and that the autistic person also carries that diagnosis. In fact, I think in some ways with therapy, it gets a little bit better. They don't have as much problem as they get older. But again, I wouldn't say that I'm the expert on Ehlers-Danlos, but I think it's, I don't see it as getting worse.
Okay, and we do have some webinars on that topic if anyone's interested in learning more. It's on our website at autismwebinars.org. We've got some good coverage of that discussion, so there may be more information in those talks. This question, or actually this is a bit of a comment, but I think one that might be dear to your heart. This person is saying, from what I've seen, the majority of neurodevelopmental programs and clinics are housed in pediatric or pediatric primary care units. Would you recommend that those programs extend age to incorporate adult providers for both special training and to ensure these patients have continuity of care? So rather than trying to get physicians who are not in peds to become experts on this, but instead have pediatrics extend care all through the lifespan the way you have? Absolutely,
no question. A big yes on that. I think that, I mean, that was the program that we originally put together, what was then called the Ladders program. And it was designed to do exactly that, that there were adult doctors, there were internists who were involved in that program, along with psychiatry, gastroenterology, pediatrics, psychology, speech and language, et cetera, et cetera, et cetera. And the idea was exactly what you're talking about, that there needs to be a continuity of care here with people who are skilled and frankly, who can work together with each other. And, you know, I frequently would say that the advantage of a clinic like that is, you know, if you've got a question, can you just walk down the hall and ask somebody who's no more than you do the question? You know, the problem with, you know, trying to seek out resources for yourself is you make a phone call, you leave a message, 3 days later somebody calls you back with the, you know, to talk about it, and by that time, frankly, at least for me, I've forgotten who the patient is and what the question was that I asked in the first place. So I'd really like to be able to have an environment where I can just ask somebody who's there. You know, if this is a motor problem, I suppose this is a patient with Ehlers-Danlos syndrome. If I could just grab a physical therapist and say, can you just take a quick look at this patient while he's here and tell me what you think, and do you think he needs therapy, or what should we be doing? That's an enormous help. It doesn't fragment care. People are talking to each other. It's much more coordinated. And yes, I totally agree. It needs to be lifelong.